Continuing education credits for physicians and other healthcare professionals is provided by VCU Healthcare Continuing Education. Check out cribsiders.vcuhealth.org for more information.
The Cribsiders podcast is for entertainment, education, and informational purposes only. The views and statements expressed on this podcast are solely those of the host.
Welcome back to the Cribsiders.
Woo!
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 There it is. I'm Justin Bird, joined tonight by our wonderful producers, Angela and Andrea. Say hi, team. How we doing?
Hello.
We're doing great.
Nice to be on.
It's a great Friday to be here.
It was amazing Friday afternoon recording, kind of a new time for us, so who knows? The potential is limitless here. Our guest tonight, Dr. Scott Hadland, is here to discuss opiate use disorder in pediatrics. But first, Andrea, can you remind us about the show?
Absolutely. So we are the Pediatric Medicine Podcast. We interview leading experts in the field to bring clinical pearls, practice-changing knowledge, and answering lingering questions about core topics in pediatric medicine.
We have a really great conversation with our guest, Dr. Scott Hadland. He is the head of adolescent medicine at Massachusetts General Hospital and Harvard Medical School. He is a teen addiction specialist whose clinical and research interests focus on preventing and treating drug and alcohol use, as well as firearm deaths. Dr. Hadland's work is funded by the National Institutes of Health and the CDC and has been published in the New England Journal of Medicine, JAMA, Lancet, and other leading journals, and featured in the New York Times, Washington Post, CNN, NBC, and NPR, among other leading news outlets.
Dr. Hadland teaches us about the differences between substance use and substance use disorder, how to counsel patients and families about naloxone, and how pediatricians can feel comfortable prescribing buprenorphine, whether in the ED, clinic, or inpatient setting. Without further ado, let's get to it. Welcome to the show, Dr. Scott Hadland. Thank you so much for joining us on the Cribsiders.
Thanks for having me.
It's so nice to have you. I meant to ask earlier, but we do this on air often. We're a very informal group and try to be equitable in how informal, and so we use first names usually during the show. Is it okay if we call you Scott?
Please do, yeah.
Excellent. Scott, we're so excited to have you. I would love to learn more about you and what you're doing. So were our listeners. And so do you mind giving us just a little bit of an intro to who you are and maybe something that you're interested in outside of medicine?
You bet. I'm Scott Hadland. I'm a pediatrician by training, and I'm chief of adolescent medicine at Mass General for Children here in Boston and an associate professor of pediatrics at Harvard Medical School. And I've built my career around taking care of teenagers. So I'm subspecialty boarded in adolescent medicine, and specifically have built a career around working with teens who struggle with substance use. And so have also gotten board certification in addiction medicine. And it's been a really exciting and interesting combo. And we built a great clinical program here at the hospital where we're treating addiction right in primary care. In terms of things that I like to do outside work, well, I've got two young kids. I've got a 6-year-old and a 3-year-old, and they take up all of my spare time in the most wonderful way. I guess the newest thing that I've taken on in life is that as my 6-year-old has started to take piano lessons, I too, as a 42-year-old man who doesn't know a thing about music, have started taking piano lessons too.
Oh, I love that. Yeah, the program that you have created and you know the work that you guys are doing is so admirable. I think a lot of places are looking to you as models of how to do this work. But I also love the two kids. I have twins on the way. It's our first and second coming, which I'm very excited about, in part because of this idea of like learning through the eyes of a kid and the things that they're excited about. So one of the things I'm most excited about is seeing what the kids get into and learning about that. So I love that that's in action in your life right now.
Well, I'm really excited for you. Best of luck with that big life transition. It's a wonderful one. Although I have to say, I didn't have to take care of two newborns at the same time.
We won't know any better. 2, 1, it's going to be tough either way. We're going to make it through.
Yeah, Justin, way to hard launch that on air.
Yeah,
but congratulations.
Yeah. I think I've talked about it, but yeah, we're excited. It's a big milestone for us. So I may be missing in some future episodes, but it's because I'm trying to put what I've learned on the Cribsiders into practice with my own offspring.
Totally fair. I wanted to ask a question about, I know you're really involved in different media, Scott, and so maybe like a piece of media that you feel like our listeners should be consuming, whether it is audio, video, a book, an article even.
That's a really great question. I think one of the best things that we can do is try to understand the issue of substance use from the teens' perspective and from the perspective of the families that we're serving. And I think a great set of resources is by an organization called the Partnership to End Addiction. And actually, in full disclosure, I partner with them on research, and so have a little bit of a bias in that. I think I'm particularly familiar with their materials, but they have a lot of great family-facing material. And so while not a book or a movie or a particular sort of piece of media, it is a website and a collection of, I think, really nice evidence-based materials that people can turn to understand how they can counsel teens and how they can counsel families. And also, a set of resources that you can direct teens and families to do their own reading.
That's awesome. And we'll have show notes on the that we can link to those and kind of share with our listeners, which will be a great resource. One of the questions I always love asking our guests is on the show, we really try to normalize failure as a part of career building and a normal part of how just the field of medicine, of life in general. And I wonder if you have a favorite failure or some example of where you felt disappointed by a result and maybe what you learned from it.
Yeah, I think to succeed in academic medicine, and look, the work is about helping young people and helping families, and yet at the same time, we do so through a system in which we hope to be able to be successful and hope to thrive, and that system has certain metrics, publications, grants, lots of sort of traditional measures. I think just as a part of the day-to-day of living and working in the academic system, you're nonstop coming across individual sort of failures or setbacks. The paper that you submit that gets rejected and then gets rejected again and then gets rejected again. The grant that you think is your best work and never gets scored. I've had all of these things happen many times. So I think that is just part and parcel of this. And I think when you perceive that people are being successful in life and aren't encountering failure, it's because they're not advertising the failures, and because they probably portray a lot of confidence that brushes it over. But we're all experiencing nonstop, often daily failure in this line of work. But that's all part of it.
Yeah, I love that, and I think it's nice to kind of have a soapbox a little bit to share these publicly with people, because I think we've all kind of experienced those, and it's a part of the normal progress, and I think it's a core part of kind of our values of kind of learning from mistakes, failures, disappointments, and building resilience and moving through. And so,
hey, Cribsiders listeners, let's talk some more about Freed. Freed is an AI scribe that listens, transcribes, and writes medical documentation for you. So here's the backstory. Gabby, a family medicine physician, and Erez, a computer engineer, came up with Freed, a solution that could help alleviate the daily burden of overworked clinicians everywhere. And for Erez, selfishly, it could mean that he would spend more time with Gabby, who was spending nights, weekends, and holidays updating medical documentation. So what does Freed do? Freed turns clinicians' daily workflow into accurate documentation instantly. There's no training time, no onboarding, no extra mental burden. All the magic happens in just a few clicks, so clinicians can spend less energy on charting and more time on what they do best. Today, more than 4,000 clinicians and their spouses have fallen in love with Freed. So Freed is this AI scribe that makes charting go away, doing your soap notes for you. It is HIPAA compliant, takes 30 seconds to learn, and costs only $99 per month. But you can try Freed for free right now by going to freed.ai. That's freed.ai. And listeners of Cribsiders can use code CRIB50 for $50 off their first month.
with that, why don't we dive into some content? And Angela, do you want to start us off with our first case?
Yeah, absolutely. So our case today is a 17-year-old patient, Dylan, he, him pronouns, for whom you're seeing for a well-child visit. Dylan's parents are concerned that he has been spending more time with an older group of friends, acting more withdrawn at home, and skipping school. You ask Dylan's parents to leave the room and complete a shades assessment, so confidential assessment. And Dylan endorses using marijuana regularly and occasionally takes pills from a friend that he thinks are oxycodone. And so I think before we get into, screening and management and all of that, I wanted to just ask, what qualifies somebody as having a substance use disorder versus maybe more simply substance use?
It's a great question, and because adolescent substance use is relatively common, and just to sort of set some understanding of where the epidemiology of this lies, actually is the case that most teens are not actively using substances. Sometimes it feels like a lot of teens are using alcohol, cannabis, and nicotine, which are the three most commonly used substances. And certainly, there is a decent percentage of young people who are using those substances, but actually in the aggregate, most teens are not actively using substances, haven't used any substances in the last month. But, having said that, some teens do use substances, and we need to be prepared as pediatricians, as clinicians, to be able to distinguish when substance use, be it experimental or recreational, starts to cross over into the realm of becoming a use disorder. And I think of substance use disorders as, well, look, they have a DSM-5 or Diagnostic and Statistical Manual 5 definition with 11 criteria. And if you have at least 2 or more of them, then you sort of meet criteria for a substance use disorder. But I actually, even as an addiction medicine clinician, don't know those 11 criteria off by heart. I think of them as falling into 3 buckets. And the first bucket is loss of control over your use. And so that's the set of criteria that include, spending more money than you mean to on drugs or alcohol, spending more time on drugs and alcohol than you mean to, trying to cut back but being able to, just sort of general loss of control. And the second bucket is negative consequences resulting from that use. And so you might be starting to have problems at school or at home, as Dylan seems to be. You might start to have relationships that break down. You might have difficulty showing up for a job. So you're starting to have negative consequences in your daily functioning. And then the third bucket are the physiologic changes. And so this is, developing withdrawal symptoms if you stop using, or developing tolerance to a substance when you use it over and over again. So I think of those 3 things when I'm sort of presented with a teen who's using substances: loss of control, negative consequences, and then these physiologic changes.
And so for an individual, in this case, we use a screening assessment to try to understand the person's substance use. In this one, it's a shades assessment. I know at our facility or at our clinic, we often use CRAFT as a screener. Is this something that primary care should be doing? Is this an evidence-based intervention? And how does this kind of help guide what your clinic visit is going to be like for this patient?
Yeah, I would say expert opinion is that, yes, we should be doing this with every teen at least once per year. And so in our practice, we do it at their annual physical exam. If you look to the U.S. Preventative Services Task Force recommendations surrounding drug and alcohol screening, you'll see that it's a little bit muddier of a picture, and that's just simply because we don't have a lot of large studies of screening and then of the outcomes that come from screening in young people. But if you ask the experts, the American Academy of Pediatrics convenes an expert task force on this topic. There are multiple clinical practice guidelines that do recommend doing routine screening with young people. And so to your point, Justin, of what screener to use, many practices do use the CRAFT screener. And that's one that we use in our practice. And just so that listeners know what CRAFT stands for, craft is actually like the word craft, like a vessel, a boat, but with 2 F's. And so the letters are C for, do you ever ride in a car with someone who's using substances? R, do you ever use substances to relax? A, do you ever use substances while you're alone? F, the first F, do you ever forget what happens because of your substance use? The second F, do your friends or family ever tell you should cut back? And then T, have you ever gotten into trouble because of your substance use? And the idea behind these questions is to understand if when a young person is using substances, are they having problems from them, or are they starting to lose control? And again, the idea here is to get at those consequences of substance use that might indicate there's a disorder.
And for an individual who is maybe not to the point of having a disorder, but is endorsing marijuana use like Dylan, or drug experimentation, taking pills in this situation, how does that kind of guide your counseling? Are you counseling Dylan? Are you counseling parents? Are you counseling for abstinence? What's your counseling visit like when, let's even say, you have a situation where the adolescent has disclosed and is open to having a conversation? What does that look like for you?
Yeah, I try to use basic motivational interviewing techniques. And you can take entire weekend or week-long courses on motivational interviewing and really dive deep. But if there are a few sort of snippets of motivational interviewing that I can pull out and share today with listeners, I think that'd be really helpful. A first step for me is to try to understand the motivations behind somebody's use. And so I'll ask every teen that tells me that they're using substances, what do you get out of it that you like? Because certainly when people engage in a behavior over and over again, there's a positive benefit they're getting from it. And often teens will tell me, well, it helps me to socialize with friends. It helps me to fit in. Some teens will tell me, hey, it helps me to relax and I feel a little bit anxious at baseline if I don't use. And so that can be really helpful for you to understand the motivations, because that information becomes helpful as you try to support change. And then help them explore together in a very non-judgmental way, what are the cons of their use? So what are some of the things that they may have noticed that are on the downside from using? So maybe people will tell you, oh, my relationships with my friends have changed, like Dylan might say, or, my coach is worried about my substance use and says that I can't play for the basketball team if I get caught again. Or somebody else might just say like, hey, I'm spending a lot of money on this and I'm trying to save up to buy my own car. It's helpful to explore these. And the idea here is to understand what are the pros, what are the cons, and how do you tilt the balance of importance of those things relative to one another. I would say specifically with Dylan, there's a real safety concern here, though. I think you can have this kind of conversation around cannabis use. But when it comes to pills, which, we can certainly talk about this today, a lot of the pills that are available on the market right now are illicitly manufactured, and they're fake or counterfeit pills that have fentanyl in them and are driving overdoses in young people. There you really need to have a thoughtful conversation about safety. Not one that's bombastic or hyperbolic or over the top, but one that is really focused on you helping to keep the young person in front of you safe.
And I would love to follow up on this, because I think this is where I struggle with, especially an adolescent, in that I had come with my thoughts of, this is dangerous, or I am concerned about you because of contamination of fentanyl, or if there is like a clear, maybe problematic behaviors that a parent has brought up or a teacher has brought up. But as an adolescent who doesn't have, complete executive functioning completely developed, or who can very easily list some of these pros of this is my friends do it, it's fun. The cons, I don't see any cons. Are there ways that you approach an adolescent maybe different than an adult in a very kind of clear logical framework with motivational interviewing? Are there ways that you try to help create that cognitive dissonance unique to an adolescent who might be, I imagine, tends to be far more pre-contemplative than other individuals who are doing motivational interviewing for behavioral change?
Yeah, I have two recommendations for practitioners that are really easy and you can incorporate right away, right now. And they're actually not motivational interviewing techniques necessarily. The first one is to give yourself a little bit of a break, that behavior change is complex. In particular, substance use is difficult to change in a single visit. You can certainly do it over time. And even though motivational interviewing can be very powerful, you're not going to, I do this all the time in my clinic. This is what I do. And it's not like I have a 100% hit rate, right? Like I'm not 100% successful. And so it is okay if you have the conversation and you think it didn't have an impact. The second thing that I would say is that you actually often do have more of an impact than you think. And there are some good data to suggest that even when a clinician just makes the recommendation that you cut back or stop your substance use, that can be relatively powerful with a young person. I think many teens hear a lot of positive messaging around substance use. They hear that cannabis, for example, is legal, it's natural, it's safe. You can now get it, at a dispensary, and it's right there for the taking. It's quote unquote better than alcohol in terms of its safety profile. So there's a lot of sort of semi-positive messaging around cannabis, and so it can be very powerful when you say as a clinician, "Hey, look, as your doctor, I actually think you should cut back, and here are the reasons why I think you might want to, because it might get you into trouble with your basketball coach, or you could save some money if you cut back on how much you're smoking, and you could finally attain that car that you've been saving up for," right? So I think the two things I would recommend is, one, like set the stakes low for yourself. It's okay if you don't win every conversation, and two, understand that even just a simple recommendation, if nothing else, can have enormous power.
Yeah, I wanted to ask a follow-up to that. So it's kind of a two-part question I'm thinking about, like when you're in the room with Dylan. And so the first is like, I think it's a little bit different when we talk about substance use in an adolescent who is underage versus an adult. And so generally we're kind of taught this, like, you should stop using it, all these recommendations that you just gave. Is there a utility to like ever use like a harm reduction approach in this setting? Like I've had teens who use quite frequently, right? And so sometimes I'm tempted to say, well, can we have strategies to cut down? But I understand if you can't cut all the way down, but then that feels a little bit strange based on their age. And then do you ever have to involve like the family or the caregivers? Like at what point do you feel like there's enough of a safety risk, if ever, that you would have to disclose to the family?
Yeah, absolutely. I think that's a great question, Angela, because I think in particular for patients who might not be able to in the moment cut back on their substance use or stop altogether. I think classically what we've done in the field of medicine and certainly in pediatrics is sort of put our hands up in the air and said, oh, there's nothing I can offer. Dylan didn't want to change. I tried, but he wasn't able to cut back. So there's nothing else I can do. But there's actually a lot we can do. And in particular, we can always partner with patients around their safety and around their health. And so in this particular case for Dylan, there's a lot of overdose prevention approaches that we could offer to him, right? We could certainly talk to him about naloxone, the easy to administer nasal spray that can reverse an overdose. We can talk about, first of all, he may not even be aware that the pills that he's buying could contain fentanyl. So we can talk about that as a safety concern. And we can let him know that, Dylan, of course, as a doctor, I'm going to recommend to you not to use these because that's the best way to stay safe. And yet, if you do use, which I hope you don't, but if you do use, remember some of the following tips. And so we can say things like, don't take the whole pill at once, break it in half or break it into a quarter and see how you feel after taking a little bit. Wait half an hour, see how you feel. Don't use alone. Use with somebody else who can call 911. Call 911 if there's an overdose, that your friend may have, and tell your friend to call 911 if you have an overdose. Have naloxone, use it. There's lots of different strategies here. And I think by banding together with a young person on safety, you then open the door for a future conversation where they trust you when they are ready to cut back. To your question about when to involve parents, that has gotten really tricky in the era of fentanyl. I think classically, we typically only involved parents, when I first got started out in training, if, say, a young person was drinking and driving and there was a clear safety risk. In the era of fentanyl, just the mere use of a pill that might contain fentanyl in it, that's a safety risk. And so I certainly have worked together with a teen to break confidentiality, but only in a way that feels right to the teen. So I'll say to the teen, hey, look, I'm so worried about your safety. I think I've got to tell your parents. What's the best way for me to have that conversation with them? Do you want to tell them? Do you want me to tell them? Do you want to be in the room when that happens? But I think we need to tell them.
That's a great way to frame it. I think of this is what I need to do and how do you want to do it to give them some control. And I like that, Pearl, a lot. I think that's a really helpful way to bring up the conversation. I do want to talk about some of these harm reduction and overdose things, but before we go to the next part of the case, going back a little bit about predictions and or kind of risk factors, I'm wondering if there's risk factors for people, for adolescents, that primary care docs should be aware of that might suggest this person is at risk of problematic substance use or even potential overdose. Are there specific things in a person's childhood history or just as the child presents and adolescent presents that you see as like a risk factor for substance use problems?
Yeah, I think that the single most important risk factor for future substance use problems is prior use of substances. And we know that the younger a young person uses substances, the more likely they are to go on to have problems with substances overall. So it's very different if a teen is vaping nicotine at the age of 13 versus at the age of 17 or 18. That 13-year-old is going to be at much greater risk of having a use disorder, really to any substance moving forward. So prior substance use, particularly at a young age, is going to be sort of your biggest single risk factor predictive of future problems. The next one, though, it is really the rule and not the exception that the teens that I care for with substance use disorders almost always have mental health concerns that very often have gone unaddressed or that the substances are helping to sort of mediate. And so most commonly we see, I would say, untreated anxiety, untreated depression, untreated ADHD, and then certainly untreated trauma or unaddressed trauma. And so I think that's an additional risk factor to think about is just, having childhood trauma or neglect or abuse of really sort of any kind is really quite common in the patients that I care for with substance use disorder. Not always, but often is a risk factor, and when present requires a more thoughtful approach to make sure that difficult part of their past is being appropriately addressed.
Americans take about 20,000 breaths a day and spend an average of 90% of their time indoors. The indoor air that we breathe can be up to 100 times more polluted than outdoor air, according to the EPA. Indoor air pollutants can cause respiratory symptoms like sneezing, congestion, scratchy throat, and even more serious health problems like lung and heart disease. So what's the solution? Air Doctor, the air purifier that filters out 99.99% of dangerous contaminants so your lungs don't have to. This includes allergens, pollen, pet dander, dust mites, mold spores, and even bacteria and viruses. So let me tell you how I've used my Air Doctor so far. It starts and ends with diapers. We set up our Air Doctor in a small room with our diaper pail, and it takes the smell out of the room. I don't know if I can say that clearly enough. It took away the smell of diapers in the room. I feel like that speaks enough for itself. So, Cribsiders listeners, we have a few offers for you. First, Air Doctor comes with a 30-day money-back guarantee, so if you don't love it, just send it back for a refund minus shipping. Second, head to airdoctorpro.com and use code CRIB, and you'll receive up to $300 off air purifiers. Exclusive to podcast customers, you will also receive a free 3-year warranty on any unit, which is an additional $84 in value. Lock in this special offer by going to airdoctorpro.com. That's AIRDOCTORPRO.com and use promo code CRIB, CRIB.
And as a bridge to our next part, which is talking about overdose, can you talk about some of and you covered some of these already, I think, in the risks that kind of blend into the consequences or the long-term and short-term comorbidities. What are some long and short-term medical and psychosocial risks of this kind of opioid use disorder in this population? And also what kind of inequities do you see in either, the use or the overdose profile or any of that?
The single most important negative downstream consequence that we think about in opioid use disorder is really overdose. And this is really critical because overdose rates in teenagers have hit an all-time high. They are, becoming a leading cause of death in young people. And we're at a point right now where the equivalent to a high school classroom of teenagers dies every week across this country from overdose. And so the game has changed. We as pediatricians, I think for a long time, haven't gotten great training on how to confront substance use disorders in our practice, but the time is now, and we need to know how to have these conversations around overdose prevention and need to know how to prescribe naloxone and make it available to young people. So that's the single biggest consequence. And of course, there are other consequences too. Opioid use disorder in the adolescent years is a very strong risk factor for persistent opioid use disorder throughout the lifespan or just substance use disorders throughout the lifespan. It's a risk factor for worsening mental health throughout the lifespan. And of course, if you are struggling with substances and not able to succeed in school, if you're not able to have your first job and be successful at it, to go to college if that's your goal, it really sets you up for a lifetime of potential adverse consequences because there's so much important healthy development that's supposed to be taking place in those years, and that can be kind of co-opted by time spent on substances. Angela, what was the second part of the second part of your question?
Totally. I was going to ask about inequities that you see in either the epidemiology of use or overdose, and if those are the same inequities that you see.
There are inequities throughout healthcare with regard to race and ethnicity, to access based on language, access based on health insurance, socioeconomic status, geographic location, whether you're in a rural area or an urban area. And all of these things seem to be just even more compounded when it comes to substance use disorders because our treatment framework, our treatment networks throughout the country are just so fragile and so inadequate to begin with. And so take any inequity and just know that it exists to the nth degree when it comes to receipt of care for substance use disorders. And in particular, we do have hard data on these. We know that among teenagers who overdose, rates are higher among, using CDC definitions of American Indian and Alaska Native youth, so indigenous youth, and also higher among youth that identify as Hispanic or Latinx.
I think this is a great place to transition to the second part of our case, which will be about overdose management. So unfortunately, a few months later, in this case, you're working in the ED when Dylan shows up as a patient on your board for an opioid overdose. A bystander who happened to be there at the time used some intranasal Narcan, and EMS transported him shortly afterwards. And so we've touched on parts of this, but how common is opioid overdose in adolescents? And are there any specifics that are more unique to the adolescent population in overdose than in adults?
Yeah, unfortunately, overdoses are becoming more common in young people. And as I said, have really hit an all-time high. And so we're really in kind of an unprecedented time. And the real driver here has been fentanyl. So fentanyl is a highly potent opioid. It's at least 50 times more potent than heroin. And the fentanyl that's in the drug supply right now is largely incorporated into these counterfeit pills that I've been talking a little bit about. These are pills that are made to look like, say, oxycodone, a painkiller, or alprazolam, an anxiety medication, but instead actually contain fentanyl, which is cheap, easy to import into the U.S., and has sedating effects, right? So if you're looking for sedating or pain-killing effects, fentanyl will do that, but these products are especially dangerous for young people who, first of all, might not know that there's fentanyl in them. And then second of all, often have no tolerance to opioids because they haven't been using opioids before. And what I think is unique about this time right now, Angela, is that the profile of young people who are overdosing has shifted. So when I first started doing this work, a little over a decade ago, the profile of the young people that I saw who were at risk of overdose were young people who had an opioid use disorder. They were using prescription pills like oxycodone, and in this case, I mean real ones that were actually prescribed, or heroin, and they knew what they were using. And what has shifted now is that I tend to think of there as being sort of three groups of young people that are overdosing right now. And the first two groups are actually the bigger of the two groups. The first group is young people who might just be experimenting with pills and may not know what's in those pills and may not have an opioid use disorder or any other mental health problem. And I've certainly met lots of families who have lost a young person who sort of met that profile. The second group, also a big group, is I think young people who have untreated mental health problems who may be seeking out a pill because they're looking for a way to relieve their anxiety or other symptoms that they may have. Or maybe they have untreated pain and they're looking for a way to address that pain. And again, they may not be aware of what these pills contain. The third group now is the original group that I mentioned, and that is young people who have an opioid use disorder. And I think, look, this group is still quite prominent. This is about 1 in 100 teenagers across the United States has an opioid use disorder. So this is like a pretty prevalent condition. And yet I think among the young people who are overdosing, they're now sort of a smaller percentage.
And one of the things you talked about earlier with kind of a harm reduction approach of having someone nearby, never using alone, having a bystander who, in this case, with Dylan, was able to administer intranasal naloxone. In the epidemiology of overdose among adolescents, is a bystander present often, never? Is that an intervention where we can kind of work on to try to get intranasal naloxone to help people in an overdose?
I think your final question, yes, we absolutely need to be getting intranasal naloxone into the hands of teens and family members. And here's why, because the real tragedy here, and we have CDC data to back this up, is that most teens who overdose aren't overdosing out in public or in the street or at school or at parties. They're actually overdosing in their own homes. And most of the time, there actually is another person at home who could potentially respond. Unfortunately, often that person may not know that the teen is using drugs, but there's often somebody home. And the majority of the time, what happens is that young person doesn't get naloxone. And by the time EMS arrives, because somebody has called 911, the teen is pulseless. And so it's too late. And so it's really critical that we get naloxone into homes. And so I think part of our work needs to be talking to families about having naloxone at home. And we can talk about different ways that families can get a hold of naloxone in a second. But what you want to do is recommend that families have naloxone. And the idea here is, I have a fire extinguisher on each floor of my house. I don't plan on burning the place down. I don't plan on having a fire, but if there ever is one, I want to be ready to respond, right? And so as much as you might say, not my house, that's not going to happen to my house, you want to be ready. And that's how we need to be with overdose and with making naloxone available. In our house, we have naloxone in our central junk drawer in the kitchen where we keep all our pens and paper and paper clips. But it's a place where everybody knows they can find it.
Yeah, I think this is so important. And I love the fire extinguisher analogy. Are there other, you kind of mentioned other pearls or things to try to approach parents maybe or teens about having naloxone nearby?
Yeah, I think teens are really an underappreciated resource in this crisis right now, because teens, whether they're using substances or not, want to be empowered to help people, right? They have really good intentions, and there's a certain resilience and strength that comes from being the person who wants to help keep other people safe. So the equivalent when I was growing up was that, at parties where people might be drinking, there would be somebody who would sort of wear the badge of being the designated driver, right? And there's a certain sort of, again, like strength and resilience that comes from that. I think the modern day equivalent is the person who brings naloxone with them. And so I think it's really important to talk to not just families about the importance of having naloxone at home, but talk to teens individually, confidentially, one-on-one about carrying it with them and bringing it to places where people might be overdosing.
Let's move on to the final part of our episode, which is going to be about treatment of opioid use disorder. So after you've seen Dylan in the ED, he wants to start treatment. And so what are some strategies you can use, behavioral, or of course, we should also get into pharmacologic?
Absolutely. Yeah, treatment is really going to be the long-term definitive way to help support somebody like Dylan, and is also going to prevent future overdoses by virtue of treating an opioid use disorder, which is a risk factor for overdose, but also of potentially offering medications that are protective against overdose. So we'll talk about those in a second. I think treating opioid use disorder in an ED context can feel very daunting, I think, to practitioners who are on the front lines. I will say there are very strong data from the adult world showing that providing treatment in emergency departments for opioid use disorder is highly effective, and programs are being rolled out across the US. So we should strive for this North Star in pediatrics as well. Having said that, if you do nothing else as a clinician, this is an opportunity to make naloxone available to the young person. And so you can prescribe naloxone, and it will typically be covered by health insurance if the patient has it. You can educate patients that they can walk into any pharmacy across all 50 states in the country and ask for naloxone through what's called a standing order. Standing orders are basically, you can get a prescription for a thing even if a doctor didn't prescribe it for you in that moment, and the pharmacist can just dispense it to you. In that case, a patient will also have it billed to their insurance, and typically it will be covered by insurance with little or no copay. So that's another good strategy. That's actually how I get my naloxone. And then the third way is naloxone became over the counter with the policy approved sort of earlier on last year and then implemented across the US in fall of 2023. And so now you can even go on Amazon and get naloxone, but you can also walk into any brand name pharmacy that you know and are familiar with and buy it there. So I think that's the first thing, because any practitioner can do that, even if you don't treat an opioid use disorder, and you can save a life doing that. In terms of treatment for opioid use disorder, probably the single most important thing is to understand if a young person is willing and interested to start on medications. There are very good behavioral treatments for opioid use disorder, but we haven't quite figured out exactly which is the right one. The studies are, at this point, still largely pending to help us really sort of home in on exactly what that behavioral treatment needs to look like. We just know that it works and it's supportive and many patients benefit from it. But, an ER doctor realistically is going to be making a referral to a place that's going to be delivering that treatment. But what the ER doctor can do in that moment is prescribe a medication to treat opioid use disorder. In teens, the only FDA-approved medication for teens age 16 and up is buprenorphine. And it is sometimes used off-label in younger ages. I certainly have done it in my practice. But that is a medication that can be prescribed now by any clinician. It used to be that you'd have to take this unwieldy 8-hour training. You'd have to register with the Drug Enforcement Agency or Drug Enforcement Administration in order to be able to prescribe it and get a special waiver. That's no longer the case. Any one of us can prescribe right now. And so we can and we should start doing that in emergency departments.
And do you ever can we talk about dosing a little bit too? Is the buprenorphine dosing for an adolescent the same as an adult, or do you have kind of a typical dosing strategy for patients you're starting on buprenorphine?
Yeah, it's a great question. In the era of fentanyl in adults, often people are starting at higher doses of buprenorphine. So buprenorphine is a film or a tablet that can be placed, that is placed under the tongue and administered sublingually, and usually comes in doses of 2, 4, 8, or if you take 2 of the 8's, 16 when you're first starting out with the medication. And often what happens on the adult side is that patients will start on 8 or 16 milligrams of buprenorphine on day 1. And sometimes it may even go up from there. In adolescence, you can still take that approach. In general, what I find is that my patients often get sedated at some of those higher doses. And so we often will move a little bit slower in teens because often 4 milligrams or 8 milligrams or 12 milligrams is sort of the dose that seems to do the best job of addressing their symptoms. And to be clear, the symptoms we're addressing here we're trying to address their withdrawal symptoms, that, the uncomfortable feelings that they experience when they stop using opioids, and then also their cravings to use opioids again. That's where buprenorphine is really powerful.
And what if a teen or a parent says, how long does he need to be on this? How long does Dylan need to stay on this? When can he come off?
It's a great question because we don't have studies. On the adult side, the data suggest in general that the longer somebody stays on buprenorphine, the better. And typically people do better when they stay on buprenorphine for at least 3 years. On the pediatric side, we don't have those same studies, and it's a different population. Many teens have just been using opioids for, maybe a year, maybe 2 years, maybe just months. And so I think that's very different from, the adults that were in the studies that I just mentioned who might have been using opioids for a decade or 2 decades. I think that is a very different population to treat. And so I think that many young people, first of all, don't want to be on medications for a very long period of time. And then second of all, may not necessarily need to be on them for a long period of time. But I tend to think of this the way that I think about antidepressant treatment. And that is that you tend to do better when you're on the medication for at least a period of months to maybe years, maybe a small number of years. And then what you want to do is try to bring yourself off the medication in a very careful, controlled way where you're carefully monitored, you have close follow-up with your doctor. And when it's a good time in life, right? You don't want to come off an antidepressant when it's the winter time and you're in the middle of college finals. You want to do it in the summer when life is easy and you don't have a lot of responsibility. You can really monitor things. And if it goes poorly, there are fewer stakes, right? I think you want to treat buprenorphine tapers the same way.
Open Evidence is the premier AI-powered medical information platform for medical providers. It is designed from the ground up for you to get trustable, verifiable, evidence-based answers to clinical queries. Open Evidence is used in over 7,000 hospitals and care centers in over 150 countries. Grounding in high-quality literature allows physicians to have the ease and flexibility of ChatGPT while also being actionable and verifiable. So I've used Open Evidence in 2 ways. First, to find primary literature. For example, you can ask it to find the most recent guidelines on pneumonia, asthma, or any medical disease of your choice. Or it can help you find that articles at the tip of your fingers, but you just can't remember the title or author. But what impressed me the most is you can ask Open Evidence to read a guideline for you. For example, you can ask Open Evidence various questions about the 2021 AAP febrile infant guidelines, and it will give you a summarized response about lumbar punctures, antibiotics, anything that you might ask. So Open Evidence is solving medical search for providers everywhere. If you haven't tried it yet, go ahead and check it out at openevidence.com/Cribsiders. It's free to all of our listeners. To help save you time and help make better decisions, go to openevidence.com/Cribsiders.
And so this is really interesting, I think, as a trainee, like finishing up residency, in terms of your statistics earlier in the episode about how surprisingly common opioid use disorder is in adolescents. I don't think I've ever seen an adolescent in my clinic, and very rarely inpatient, that is on buprenorphine. And so I'm wondering if you could talk about some of the barriers to, like, why are we seeing, so few adolescents on this medication, and, are there any inequities in the prescribing profile of who we tend to prescribe it to?
Right. Your experience is backed up by data in that we know that at least in some of the studies that our group and other groups have led sort of over the last decade, we know that teens are probably about 1/10 as likely to get buprenorphine as adults. And so that differential, that disparity is very clear. There's a lot of reasons for it. For a long time, there were insurance barriers for young people who had insurance, in that there were prior authorizations for a teen to go on buprenorphine. Co-pays were excessive. A lot of that has gotten better, but the main issue that we live with right now is that our workforce is insufficient. That, especially if you live in a rural area in this country, you may have no clinician that you can turn to who has pediatric expertise, who is willing to prescribe buprenorphine to somebody who's a teen. For miles, most counties, in fact, don't have opioid addiction treatment programs in them across the U.S. Even programs that do have opioid addiction treatment programs, a recent study that Dr. Carolyn King from Yale did that was really thoughtful. She did a secret shopper study to call up addiction treatment programs for teens to find out how many were actually offering buprenorphine, which is the standard of care and a potentially life-saving medication. It was only 1 in 4 programs actually offered this evidence-based medication. And so we know that there are enormous access issues. And, we talked earlier on about inequities. Again, this is where they're even more compounded because those access problems are difficult for all teens and all families, but they are exponentially worse, often for youth of color and in communities that have been historically underserved.
And related to that, as far as workforce development, I have a couple questions, but I'll start with one. Now, without an ETS waiver requirement, any pediatrician could prescribe buprenorphine to an adolescent without an addiction medicine certification. I imagine some of the hesitancy might be less familiarity with the medication or concerns about dangers. Can you talk a little bit about what are some of the side effects or things that people might be worried about right before prescribing buprenorphine for the first time in their practice?
Yeah, I would say it's a medication that's easier to prescribe than many other medications that we prescribe as pediatricians. And so, to start with the positive, I think it can be done. And I'm seeing a growing number of pediatricians who want to do this, take it on, who want to be the champion for their particular practice to help serve young people. And I think that's fantastic. And it speaks to the fact that people are motivated, want to do this work, and it is relatively easily done. There are some challenges. We have to think very thoughtfully about not giving somebody buprenorphine too soon after the last time that they've used opioids. And so a young person who, may have just used fentanyl a few hours earlier, if you start them on buprenorphine, because it is a partial opioid agonist, meaning that it binds to the opioid receptor without having a full pharmacologic effect, it can put someone into a relative withdrawal that we call precipitated withdrawal. And that can be really uncomfortable. So we want to make sure that we wait usually at least a period of 12 to 24 hours after somebody has last used fentanyl, and often has to be a little bit longer depending on how much they've been using in order to see that they're starting to go into their own withdrawal before you administer them buprenorphine. I think that's probably the key thing to think of when you're prescribing and to counsel teens and families around. Otherwise, certainly there are some side effects from buprenorphine, like some sedation or constipation, and when it's administered for longer periods of time. Those are usually addressed by managing the dose, just like you would any other medication. And I should say, a lot of people have historically been worried about buprenorphine as a medication that, quote unquote, you can get high off of. The truth is, it's a medication that doesn't produce euphoria because it's a partial opioid agonist. It's not a medication you can easily overdose on because it's a partial opioid agonist and doesn't dramatically suppress respiratory function. And so it's a very safe medication to be prescribing.
And in the adolescents and adults, will use injectable buprenorphine on sometimes. Is that something that you've seen done in adolescents? And is there a age range of when you would consider an injectable buprenorphine that could be a monthly depot shot rather than someone taking a medication once or twice a day?
Yeah, absolutely. And so, to be clear, various injectables may or may not sort of have FDA approval for use in this age range. And yet we know that when it comes to, for example, medications to prevent pregnancy, right? We know that adherence is often higher when we use long-acting forms of pregnancy prevention, when we use intrauterine devices, when we use implants, and even when we use injectables relative to a medication that you have to remember to take daily. So there's enormous promise in injectables in teenagers. And so even though it may be off-label usage, many practitioners are using them, and I think with a lot of success.
So kind of as a mini summary before we wrap up and has a question in it, it sounds like, for our listeners who may be practicing many different settings, if you're in the ED and you see this, probably naloxone is within your scope of practice that you should be prescribing or thinking about. If you're inpatient or in the clinic, then you probably should be prescribing naloxone at the very least, and then considering initiating buprenorphine. And if you're inpatient with good clinic follow-up, I guess A, is that correct? And then B, is there confidentiality considerations with this? Like on your insurance, would it show up that you've prescribed or that the team has picked up naloxone or buprenorphine at their pharmacy?
Those are fantastic questions because in particular, that second one is something that we think a lot about. To answer your first question, though, I think any clinician anywhere can prescribe not only naloxone, but also buprenorphine. The one challenge, and I think your question raised this nicely, is that if you're in an emergency department or if you're an inpatient physician who isn't necessarily going to be able to follow up with the patient long-term and continue to prescribe them buprenorphine, that becomes a little bit tricky because you have to figure out who's going to be the long-term provider of that medication. And so that can be limiting. So it's important for ED docs and for inpatient docs to understand what are the resources in your community, what are the outpatient clinicians that you can refer patients to for long-term buprenorphine prescribing. We do worry about confidentiality issues throughout the world of adolescent medicine, whether it's on the topic of addiction or reproductive health or whatever it may be, because yes, it is certainly possible in many states and for many health insurance companies to receive an explanation of benefits that has diagnosis codes on it or procedure codes that might indicate that you have an opioid use disorder diagnosis or that you receive buprenorphine in a clinical setting. And so that is certainly possible. It is worth, as you start to take on this work, trying to understand what happens where you practice. Very fortunately, our Medicaid program, Mass Health here in Massachusetts, doesn't do explanations of benefits for teens. And so that puts us in a position of not having to worry about it. And other insurers have followed suit, but it varies widely across the country.
And I have one more wrap-up question for treatment that is an annoying double-barrel question. But in thinking about kind of alternative treatments, do you see adolescents having some success on methadone and like navigating those regulatory barriers and doing methadone and other treatments, things like inpatient rehab units? Are those evidence-based things that we should be thinking about for patients that seem to be struggling with substance use?
The truth is we don't have enough data on either of those interventions at this point, to be really clear. My sense is that because methadone is such an effective treatment in adults, it's probably also a very effective treatment in adolescents. But until recently, adolescents, it's been almost impossible for them to get access to methadone treatment. You know, methadone is typically administered in an opioid treatment program, a so-called methadone clinic that's separate from our traditional healthcare environments. And it's really difficult to find programs that are willing to take on young people under the age of 18. And to be fair to the young people too, you know, I don't know if you're a teen, if you want to get your treatment alongside, you know, somebody who might be 40 or 50 getting treatment in the same place. And so we have a lot of work to do to try to make make methadone accessible to young people in a way that is developmentally appropriate. And I think that's going to take policy change. And there's a big drive right now to make methadone available, potentially in primary care, you know, or in addiction treatment programs where you have, say, a board certified clinician like me or you, Justin, I think are one too, to be able to prescribe them. But we're not there yet. In terms of residential treatment programs, we don't have data to tell us that they're any way better than outpatient care. Anecdotally, I can say that because sometimes teens are often struggling not just with addiction, but addiction in the context of struggles at home or sort of like struggling deeply with mental health challenges that makes it difficult for them to receive care outside of a really intensive environment. It often is the case that young people do need to go to residential treatment for their addiction, but it's often not because of the addiction, but because of the other things that are going on.
No, I think that's such a great point. And actually, there's a plug for a Netflix documentary that I saw recently, Recovery Boys, I think is what it was called. It's young adults, not so much adolescents, but talks about some rehabilitation programs that are very much escaping the idea of getting people away from these kind of unstructured, very chaotic lives. And not to ruin the movie, but they do quite well in some of these structured facilities. And then the transition back is really where the challenge kind of comes back again, which I imagine is true for adolescents as well.
Absolutely.
So we've really gotten to talk about, you know, screening for substance use disorders, but also really differentiating just substance use in general. We've talked about treatments. We've talked about the different types of treatments and where there's evidence, how to talk to parents, how to talk about harm reduction, abstinence. Are there core take-home points that you think you want our listeners to really walk away with?
I would say the first one is don't shy away from this topic. It's easy to not talk about substances with teens, and yet it is an incredibly valuable opportunity and rewarding opportunity I find in my day-to-day work, and one that can have an enormously impactful influence on a young person's life, especially if you save a life by talking to them about safety as it pertains to fentanyl and naloxone and how to prevent and respond to overdoses. And when you do have these conversations, approach them calmly, rationally, and from a place of curiosity. So rather than shaking your finger and coming into a conversation sort of telling a young person what to do, explore the reasons that they use. Make a clear recommendation that you don't want them to use and you'd like to help to support them in doing that, but then also let them know that you're here even if they can't do that, and that their safety is what's most important to you. I really think practitioners need to avoid being hyperbolic and bombastic, as I said before. And that includes not just when talking about fentanyl, but actually it becomes really important when you talk about, say, cannabis use, which, cannabis use has a number of downsides for young people. And I spend a lot of time helping young people to not use cannabis because it causes them problems. And yet it is not a lethal substance use disorder to struggle with cannabis. And yet many teens will hear a lot of bombastic language around, don't do that, it'll kill you. And it's really important that we be realistic and measured when we talk about substances, so that when we do talk about substances like fentanyl, which actually can potentially be lethal, young people's ears perk up and they listen to us and they understand that this is somebody I can trust because they've been honest with me before.
Before I do the very last closing, one other thing we didn't talk about, what about fentanyl test strips for harm reduction? Is that something you counsel adolescents on at all?
Yeah, I think fentanyl test strips are a potentially really promising strategy for young people. So these are test strips that you can dip into a little bit of liquid into which you've dissolved some of the drug that you're about to use. So a teen might, for example, break off a little piece of the pill that they're thinking about taking, grind it up, dissolve it in some water, and then dip one of these fentanyl test strips into it. And then you let the fentanyl test strip lay flat for 2 minutes. And if it's a positive test, it will go from 2 lines to 1 line on the test strip. It's sort of the opposite of a COVID test, which is, I think, very confusing for many people. So you sort of have to talk through that. And fentanyl test strips are available through many state and local health departments, often for free. Here in Massachusetts, we can have them mailed to our clinic so that we can give them out to patients. I think they're a promising strategy, but maybe not for the reasons that you might think. In an era in which every pill that a young person buys off of social media or gets from a friend should be presumed to have fentanyl in it, your pretest probability that something has fentanyl in it is really high. You kind of have to assume that everything has fentanyl in it. And so I sort of find myself asking, what's the utility of testing it? Because you should just assume that everything's got fentanyl in it. And if you test it and it's negative, maybe you tested the wrong part of the tablet that didn't have any fentanyl in it, or maybe you did the test wrong, or maybe it's a faulty test. There's a lot of reasons why you shouldn't believe the test, even if it is negative. So I use fentanyl test strips as a centerpiece for a conversation where I'm talking to a young person about safety. I'm letting them know, I feel so strongly about your safety and I'm so focused on that I'm willing to have a conversation with you about how you can safely use drugs, even though you might expect me as a pediatrician to tell you not to use drugs. And that's my recommendation, but I'm still here talking to you about how to keep yourself safe. And so fentanyl test strips are a nice centerpiece for that conversation, even if as an intervention, I wonder about their utility.
That seems like a nice way to kind of build a therapeutic alliance maybe sometimes.
Exactly.
Thank you, Dr. Hadlin Scott. We really appreciate you sharing your time, your expertise with us and with our listeners. I think this has been a great episode, very helpful for helping kind of overcome a lot of those barriers and fear of buprenorphine and drug use. So we thank you for coming on to the Cribsiders.
Back at you. Thank you so much for having me. It was a lot of fun and great to get to chat with you, Justin. Reach out anytime that you want to connect on anything whatsoever. And Angela, you and I are meeting soon too.
Love it.
Looking forward to it.
The new number is...
All right, y'all. This has been another episode of the Cribsiders.
It's for the kids.
Get show notes and sign up for our weekly Knowledge Food Formula Feeds newsletter on our website at www.thecribsiders.com.
We're committed to providing you with high-value, practice-changing knowledge, and to do that, we need your feedback. So please subscribe, rate, and review the show on Apple Podcasts or your favorite podcast player. You can also email us at thecribsiders@gmail.com. Special thanks to our producers for this episode, Dr. Angela Zane and Dr. Andrea Silvas, our showrunner, Dr. Sam Mazer, and our wonderful social media team on Twitter, Instagram, and Facebook. I've been Justin Lee Burke.
I've been Andrea Silvas.
And I've been Angela Wising. Thanks, y'all, and have a good weekend.